Hello, my name is Paul Richard. I'm a pediatrician trained in hematology, oncology, blood and marrow transplantation. We have a special interest in MPS I, Mucopolysaccharidosis type 1, and its treatment. But today we're talking about the genetic counseling and the importance of that in the diagnosis and management of the families affected by MPS I. MPS I, or Mucopolysaccharidosis type 1, is a rare autosomal recessive storage disease.
Part of the MPS group of disorders. This particular disease results from mutations in the alpha L iduronidase gene or the IDUA gene. Decreased function of the IDUA gene leads to the accumulation of glycosaminoglycans or GAGs within the lysosome. And this accumulation of substrate or storage material is what leads to the disease. Disease severity can be quite heterogeneous, and the onset of symptoms and signs can vary based on the severity of the disease and the types of mutations that are associated with it. Severe MPS I is the most common phenotype. It's approximately 1 in 1,000 births, whereas the less severe forms or attenuated forms are approximately 1 in 500,000. It's important to understand that there are many organ systems that are affected by this disease. Geneticists may establish the diagnosis initially, but these patients have orthopedic problems requiring care by the orthopedic teams. You can have neurologic aspects of the disease, and the neurologist and neuropsychology evaluations are important as well. They have pulmonary and airway related issues, can have obstructive apnea, can be difficult to intubate. Virtually all the patients with severe disease have cardiac related manifestations as well, thickened valves in particular, but may have decreased cardiac function. You have corneal clouding, it can have retinal abnormalities as well. So evaluations by ophthalmologists are important. Hearing issues are also an important aspect of the disease. Many of these patients don't pass their newborn screening tests, for instance. They can have conductive hearing loss related to fluid that accumulates in the ear. They can also have sensorineural problems as well. Restrictions of range of motion is inherent in the disease, and interventions and optimization of function by occupational therapy and physical therapy can be important parameters. In terms of treatment, enzyme replacement therapy is available, which commonly is administered by the genetics, but for the severe form of the disease, the standard of care is to proceed to an allogeneic blood or marrow transplant. But an important aspect of the care of these patients and helping the family with these issues is the genetic counselor. The disease is autosomal recessive in its inheritance. Again, the incidence is approximately 1 in 100,000. The parents would be obligate carriers, but because enzyme activity of 50% is not associated with a phenotype, there'd be no reason for the family to understand that they have their carriers for the disease. Based on the inheritance pattern, 1 in 4 children would be expected to be affected. 1 in 4 would be homozygous unaffected, and the remaining 50% of children would be carriers. Related to discussions with the parents, communication of the inheritance pattern, of course, is key. That 25% of each subsequent pregnancies could result in an affected child. There is availability of testing and to determine if a patient or if a fetus may be affected. There are other opportunities for families in terms of planning that can decrease these risks, including sperm donation or pre-implantation genetic testing. One situation that occurs commonly is if a patient is shown to have Hurler syndrome and they have older siblings, whether the siblings would potentially serve as a donor for the transplant would be an important consideration. If those patients do not have Hurler syndrome, and generally if they were significantly older, that can be effectively ruled out, there would be a 2/3 chance that they would be a carrier and a 1/3 chance that they would be unaffected, not a carrier. One of the considerations for an affected child with Hurler is the choice of the donor. The gold standard has been to use a HLA-matched sibling, but there are disadvantages to using a sibling that might be a carrier. Assuming that an older sibling does not have Hurler, there'd be a 2/3 chance that they would be a carrier and 1/3 that they would not have either of the mutations. Because the enzyme expression in a carrier would expect it to be approximately 50% of a homozygous unaffected individual, the identification of carriers is an important consideration in choosing a donor. The reason that we generally do not use a carrier is because there is some biochemical evidence, at least, that transplanting with a heterozygote leads to decreased enzyme production and decreased correction. So this is biochemical evidence. Enzyme replacement decreases GAG, but not as much as transplant with a heterozygote donor. And that is also significantly less in terms of correction than transplant with a fully unrelated, unaffected donor. So an important question may be whether potential siblings should be tested. And so an important consideration may be whether siblings of an identified patient with MPS I should be tested. In the situation I discussed earlier, if they're being considered as a potential donor, we would generally do the HLA testing first. If they were not HLA matched, we would not do any additional testing. However, if they were HLA matched, we would go on to determine whether or not they were potentially a carrier. Generally, we would use molecular testing to determine that. Otherwise, there's really no reason to test a pediatric patient that might be a carrier. There's no phenotype associated with the disease. And it's really only as the families or as the patients are considering starting a family down the road that they may want to do their testing. An important consideration is the genotypes that are associated with this disease and whether that correlates with phenotype. So in the Hurler patients, the mutations generally are nonsense mutations. In contrast, in the attenuated patients, the mutations generally are missense ones. As you might expect, there's a large number of potential combinations here. And even though for the majority of patients, based on their genotype, we'll be able to establish a likely phenotype, this is not universal. Many of the genotypes that have been described in the MPS I registry are presented here. W402X mutation and the Q70X mutation are null mutations that are present in a majority of the cases of severe disease, either homozygous for each one of those mutations or heterozygous for both. There's a number of mutations that have also been associated with attenuated disease, but again, there's a huge number of potential combinations here. And while the majority of the patients will be able to anticipate what the phenotype would be, for instance, if patients are picked up by newborn screening, this is not yet something we can establish for each patient. MPS I was added to the recommended uniform screening panel in 2016. As you know, each state determines what diseases they're going to be screening for, and thus far, 20 states have instituted screening now for MPS I. It's critical to make this diagnosis as early as we can. Outcomes are quite clearly linked to the onset of therapy or the age at which therapy is instituted, both for enzyme replacement therapy, but allogeneic transplant as well. So the opportunity to identify these patients very early in life and to begin therapy will play a large role in what their overall outcomes and quality of life will be later. In terms of additional information regarding the disease, the MPS Society has a wealth of information, and the National Society for Genetic Counselors, American Board for Genetic Counselors also can provide additional resources in terms of assessing patients and counseling them. So in summary, MPS I is a rare autosomal recessive disorder. It is progressive. There are various phenotypes. The severe form is lethal without therapy. It has now been placed on the recommended uniform screening panel. There's 20 states that are currently screening, but this is increasing on an ongoing basis. Being able to identify these patients early in life can shorten the diagnostic odyssey and allow us to intervene earlier, which is hugely important in achieving the best outcomes possible. Discussions with the family regarding a diagnosis of MPS I will be critical in helping the family better understand what the implications of the disease are and help them make better informed decisions moving forward. This is Paul Orchard, and I appreciate your time and attention.